I'm going to go pretty quickly. I'm going to be talking about, obviously, the opioid addiction epidemic, and I think the title of this talk is How It Happened. And what I'll do is I'm going to start off by talking about the it. Not that everyone here needs to be convinced that we have an opioid crisis, but what I'll try and do is frame the problem so that we all better understand it. And then I'll talk about how it actually happened. And I think it is really important to understand how we got into this mess, because understanding how we got here will help us figure out how to respond to the problem. So I have no financial relationships with pharmaceutical companies, and after you hear my talk, I think you'll understand why no pharmaceutical companies would want a relationship with me. I'm going to start by saying something that should be very obvious, but really isn't. When we talk about opioid pain medicines, when we talk about drugs like hydrocodone and oxycodone, we're talking about drugs that come from opium. They're semi-synthetic. You start with opium to make hydrocodone and oxycodone, which is very similar to how you make heroin. You start with opium to make heroin, and heroin is a semi-synthetic opioid, just like hydrocodone and oxycodone. The effects that the prescription opioids produce in the brain, the effects that oxycodone produces in the brain, are indistinguishable from the effects produced by heroin. If you were to give an experienced heroin user the opportunity to self-administer oxycodone or heroin in a lab setting, and this was done at Columbia, the heroin user can't tell which is which. And if you ask them, well, which do you like better, the oxycodone actually beats out the heroin. It's not statistically significant, but they like the oxycodone a little bit better than the heroin. So my point is that when we talk about opioid pain medicines, we are essentially talking about heroin pills. Now, to say that doesn't mean we should never prescribe them. These are very important medicines for easing suffering at the end of life. They play a very important role when used to treat acute pain a few days after major surgery or a serious accident. Unfortunately, the bulk of the prescribing in the United States, the bulk of our consumption, is not for end-of-life care or a few days after major surgery. The bulk of the consumption is for common conditions where opioids may be more likely to harm a patient than help a patient, and I'll talk more about that. We have so many Americans on opioids chronically that drug companies can now make money selling medicines to treat the side effects of being on opioids. Probably many of you saw during the Super Bowl this year this advertisement for a drug to treat opioid-induced constipation, and there's even an acronym for it, OIC. Do you have OIC? Ask your doctor for Movantik. That's how many Americans we have chronically on opioids. We have so many Americans chronically on opioids chronically that we've seen a very sharp increase in infants born opioid dependent. These are infants that need to be treated for withdrawal at the beginning of life. And this is becoming an expensive problem in states where it's most severe. This is data that was published from Tennessee on the rise in infants born with neonatal abstinence syndrome. But there's data very similar to this from states across the country, and nationally we've seen a very sharp increase in infants born opioid dependent. We've also, by the way, seen a very sharp increase in children winding up in the foster care system because their parents are opioid addicted. So this really is a problem affecting us from infants to late in life. The CDC put out this slide about 4 years ago. I think it was it was in 2010 when they put out this slide. And when they put out this slide, I just updated it at the top there with the number of Americans who had died of a drug overdose in 2014. When they put out this slide, they started to publicly use the term epidemic to describe the opioid crisis. And when they started referring to the problem as an epidemic, when they used the epidemic term, they were criticized. They were criticized by industry-funded pain organizations that said, this isn't an epidemic, you're exaggerating. And by calling it an epidemic, you're going to scare doctors from treating patients with opioids for pain. You're going to worsen the problem of pain in America. And CDC responded by saying, we don't use the term epidemic lightly. And then they put out this slide to make the point that this isn't just an epidemic, but that it's the worst drug addiction epidemic in recent US history. And so the point that they're making with this slide, this box here that says heroin, that's showing you the rate of drug overdose deaths during the height of the heroin epidemic in the 1970s. And this box here that says cocaine, that's the crack cocaine epidemic of the late 80s, early 90s. And their point when they put out this slide was that overdose deaths were far higher than they were even at the height of these two epidemics combined. If you put this box on top of that box and drew a line across, you'd see far more overdose deaths. And this, as I mentioned, this slide is old, so this last bar was 2007. What happened in 2008 is the bar went higher, and in 2009 it went higher, 2010, 11, 12, 13, 14. Each year for the past 20 years, we've set a new record for people dying of drug overdoses in the United States, and then the next year we break that record. Now this slide is just showing you drug overdose deaths. It's not showing us what drugs are responsible for the overdose death. That's on this slide. And although obviously heroin is an opioid, heroin is shown green on the bottom, and prescription opioids are shown here in red. And you could see what really drove that sharp increase in overdose deaths in the United States has been prescription opioids. Even cocaine has come down. These are benzos being involved in overdose deaths, and this is a concerning trend. The main driver has been, up until 2010, had really been prescription opioids. Now, after 2010, things began to change a little bit, and you see that here. On this slide, we're focusing just on opioid overdoses. And again, prescription opioids are shown in red. Heroin is shown here in green, and the total is in black. And what you see very clearly is that starting in 2010, or really after 2010, we began to see a sharp increase in deaths involving heroin. Now this sharp increase has led to a popular media narrative. And it's not just the media, but there are even some pretty smart folks who are making a mistake in interpreting this increase in heroin. What you're hearing is that there was a crackdown on painkillers that's led to a new heroin problem. And that really isn't what's going on. It is true that among people who are heroin users today who developed opioid addiction over the past 20 years, as distinct from people who became opioid addicted in the 70s, who really did start with heroin, it is true that people who have become opioid addicted over the past 20 years, the vast majority developed opioid addiction through use of prescription opioids and then switched. That part is true. But it isn't true that there was a sudden switch over to heroin. The reason that overdose deaths starting in 2010 overdose deaths involving heroin began to increase rapidly is because the heroin supply beginning in around 2010, 2011 starts to become much more dangerous. Increasingly it has fentanyl mixed into it, illicitly synthesized fentanyl. The switch over to heroin is not new. You see it on this slide. So on the right, you're looking at African Americans. On the left, you're looking at whites. And the colors of the line are referring to age groupings. So I want you to look at this group, 20 to 34 years old. If you look at African Americans, 20 to 34, you see there's actually been a decrease in heroin use among blacks ages 20 to 34. And that decrease is really, that's a trend that's been in place for over 20 years. And crack cocaine as well. In the inner city, there are still, and I'm from New York City, in South Bronx, East Harlem, Central Brooklyn, neighborhoods that were hit hard with heroin in the 70s and crack cocaine in the 80s and 90s. There are still heroin and crack cocaine users in those communities, but they're really an aging, shrinking cohort. Young adults and adolescents in those communities are staying away from crack, and they're staying away from heroin. There's heavy marijuana smoking, blunt smoking, and sometimes alcohol combined with it, but they're staying away from hard drugs. But if you look at whites, ages 20 to 34, and this graph starts at 2003, but the increase begins in the late 90s, you see a skyrocketing of heroin use among young whites ages 20 to 34. This didn't happen 3 or 4 years ago. It started happening at the beginning of our prescription opioid crisis. What was happening is that young people who were becoming opioid addicted through use of prescription opioids, and it could have been for medical use of prescription opioids or recreational use of prescription opioids, or what's very common is a young person with a brief medical exposure from dental work or from a sports injury. There's that brief exposure, they like the effect, they use for some period recreationally, and then they develop addiction. Regardless of how the young people get addicted, when they get addicted, they have a hard time getting doctors to maintain them on a large supply of opioids. Now, it's not that doctors and dentists don't have trouble prescribing opioids. It's not that they have trouble prescribing opioids to young people. Unfortunately, doctors and dentists are pretty comfortable prescribing lots of opioids to young people. But doctors don't like giving healthy-looking 25-year-olds a large quantity of pills on a monthly basis. Unless the doctor is a drug dealer, they get uncomfortable doing that. And from the beginning of our opioid crisis, young people who were getting addicted through use of prescription opioids would turn to the black market to maintain their supply. And if they were in a region of the country where heroin was available, they switched, because the price for the pills on the black market is very high. And what's happened over the past 20 years, and I think this is discussed in Sam's book, what's happened over the past 20 years is that heroin has moved into more regions of the country where it wasn't previously available to meet the demand for it by these young people who are opioid addicted. We shouldn't forget there's an older group that doesn't need to turn to the black market. When they get addicted, and they're usually developing, the people 40s, 50s, 60s, 70s, and 80s, when they get addicted, even when their own primary care doc starts to get uncomfortable, maybe the patient is coming in early, asking for higher doses, the primary care doc doesn't want to label them with the diagnosis of addiction. Often these patients because they're saying, I'm taking extra pills because my pain got worse, many of these patients wind up getting referred to pain management. They don't generally wind up on the black market. Not that that's not going to start happening, and I think we should be concerned about it happening, but the older group is able to easily obtain pills from doctors. And there's another reason why that narrative of a crackdown on painkillers that caused a sudden rise in heroin, there's another reason that narrative isn't true, which is that there really hasn't been a crackdown on painkillers. We are still massively overprescribing opioids in the United States. In the past couple of years, there's been a plateau in prescribing, and it's come down a tiny bit, but there's still massive overprescribing. The closest thing to a federal crackdown or a federal intervention was the upscheduling of hydrocodone combination products, putting Vicodin, which had been in Schedule 3, into Schedule 2, but that didn't happen until the fall of 2014. So what also is not known is that older group, the group I mentioned that's able to more easily obtain pills from doctors, it's that group that has the highest rate of opioid overdose death in the United States. So you'll see it here on this slide. The age group with the highest rate of an overdose involving opioids are people 45 to 54 years old. You'll see for heroin it's different. For heroin, the age group with the highest rate of an overdose is 25 to 34. But the way the media covers our opioid crisis, I think many of us tend to think that it's young people running around taking drugs to get high, accidentally killing themselves. And when the reality is it's that middle age group that's able to get pills more easily from doctors that has the highest rate of overdose death in the United States. So our opioid crisis is defined sometimes as a prescription drug abuse problem or a heroin abuse problem. I don't really think we should frame it as an abuse problem because it sort of puts in people's mind that the issue we're dealing with is a lot of people out there behaving badly, taking drugs because it feels good, and they're accidentally killing themselves in the process. And that's not really what's going on. People who, the majority of the deaths are occurring in people who developed opioid addiction. And once you're opioid addicted, you need to continue using opioids simply to avoid feeling awful. These are people who really are suffering with a condition for which they need treatment. So what we're dealing with is an epidemic of opioid addiction, and I'm going to show you that happening with these maps. So this is a map from 1999, and I would argue that the opioid addiction epidemic began in 1996, which is probably, it's a pretty bold thing for me to say. I know what year our epidemic began, but you'll understand why I would say that in a moment. So this is 3 years into the epidemic, and this is data from state licensed drug and alcohol treatment programs that ask people when they come in for treatment, what's the primary drug that you're addicted to? These are the people who said that the primary drug they're addicted to is a prescription opioid. And you'll see that in 1999, a few states had already lit up. The states with the highest rate show up as red or maroon. A few states had lit up as having this high rate of individuals coming in for addiction treatment who were addicted to prescription opioids. So I want you to watch what happens to the color of the map as we go forward in time. So this is 1999, 2001, 2003, 2005, 2007, and 2009. What you can see is that in just about every state in the country, there's been a very sharp increase in the prevalence of people with opioid addiction. And when you have a sharp increase in a disease over a short period of time, that is how you would define an epidemic. Now, this is the data that was used to make these graphs came from the same sources that for the making of those maps I just showed you. So this is the demographics of the folks coming in for addiction treatment who are saying that the primary drug that they're addicted to is a prescription opioid. And so this is the most current data we have right now from 2013. And some of this is a little interesting. For example, it's a little interesting that you see for males and females that the height is so similar. If I put up cocaine or heroin or other drugs, you generally see far more males than females showing up for addiction treatment. But for prescription opioids, it's pretty similar. It's not that unusual that you see this young adults most likely to come in for treatment, and it's not that there aren't quite a few older people who are opioid addicted, but they're less likely to come in for treatment. And certainly if you're being sent to if your primary care doc is sending you to pain management rather than to addiction treatment, it's the younger folks that are more likely to have to be coerced into treatment by family. So that's not that unusual. But there is something striking on this graph that I don't know if anyone's noticed it yet, which is the color of the line. The color of the lines are referring to racial groups, and you're pretty much looking at a blue line. Try to find other racial groups. African Americans would show up as red. You barely see them register at the bottom. To say that this epidemic is disproportionately white is an understatement. It's really striking how white this epidemic is. And I think it's an important clue as to what's caused our opioid crisis, an important clue as to how we got here. Because I'll tell you my theory for why the epidemic is so white. I believe it relates to prescribing practices. Now, it has been shown that if the patient is black, the doctor prescribes more cautiously. It would seem that if the patient is black, the prescriber may be more concerned about the patient getting addicted, or maybe the patient selling their pills. And if the patient is white, they're prescribing as if there's nothing to be concerned about. And obviously, we should prescribe cautiously for all of our patients. What I think is happening is that racial stereotyping is having a protective effect on non-white communities, and so that the black patient is less likely to become addicted through pain treatment, and the black household is less likely to have prescription opioids in their medicine chest. So the fact that this epidemic is so white is leading to some other striking findings. There was a paper published recently by two economists who were Nobel Prize winners. They actually didn't win the Nobel Prize for this paper, but they published this very interesting finding. What you're looking at here is death rate of middle-aged people, different populations of middle-aged people, 45 to 54 years old. And the fact that these lines are coming down is showing you that the death rate has been decreasing. And if the death rate is decreasing, that's a good thing. That means people are living longer. So these lines coming down are all very positive public health trends showing you that middle-aged people are doing better, less likely to die. And this green line that says France, that's middle-aged people in France, and you see this really nice trend of a declining death rate. This is Germany, there's Sweden, Canada. Where you, this is USH, that's United States Hispanics. You see the thick dark blue line. For all of these different populations, you see this very positive public health trend. The one area where there's a clear deviation starting in the late 90s is for white people in the United States who are 45 to 54. And when they drill down to see what's causing white people in the United States to have an increase in the death rate, when for all of these other populations it's been decreasing, well, these were the drivers. And you see that chronic liver disease played a role, suicides have played a significant role, but the primary driver has been poisonings, which are drug overdose deaths, the majority of which involve prescription opioids. Now, this is an old slide that was made by Len Palazzi, a medical director at the CDC, who had the issue of poisoning deaths on his plate and was trying to understand what's causing poisoning deaths involving opioids to skyrocket. And so he did something really interesting several years ago, which was he charted out here in orange deaths involving prescription opioids. And then here in yellow, he charted out sales involving prescription opioids. And what he showed was that both increased in parallel. And what he argued in his paper is that this epidemic has been caused by a change in prescribing practices, that as the medical community became more aggressive in their use and their prescribing of opioids starting in the late 90s, that it led to this parallel increase in deaths involving opioids. What he was really saying is that this epidemic has been caused by the medical community. This is a more current slide by the CDC. It's making the same point Len was making many years ago. The green line represents opioid consumption in the United States. The red line represents deaths involving prescription opioids, and the blue line represents addiction treatment for prescription opioids. And this has become actually the CDC's chief speaking point on our opioid crisis. What they're saying is that as that green line has gone up, it's pulling up the red line and the blue line. That overprescribing of opioids is really driving our epidemic. And in 2008, I remember reading a report by the International Narcotics Control Board, which monitors global consumption of opioids. The report said that the United States, with 5% of the world's population, was consuming 80% of the world's oxycodone supply and 99% of the world's hydrocodone supply. In other countries, hydrocodone is just used as a cough suppressant. In the United States, hydrocodone combination products have been the #1 most prescribed medicine in America. More prescriptions for Vicodin-type drugs than for blood pressure medicines or statins or antidepressants. And that was in 2008, and yet consumption continued to increase. It's leveled off, as I mentioned, in the past couple of years. So the CDC's point is really clear. What they're saying is that we may not be able to bring the epidemic under control until that green line begins to come down. And of course, it can't come all the way down. Opioids are essential medicines. But what they're saying is that we really need to see that green line come down if we want the red line and the blue line to ultimately come down. The manufacturers of opioid pain medicines don't agree with the CDC. They really don't. I'm not just saying that. What they argue is that the green line can and should continue to go up because 100 million Americans are suffering with chronic pain and many don't have access to opioids. But if we make the pills harder to crush for snorting or injecting, and if we teach doctors what they call safe and effective opioid prescribing for chronic pain, if we teach them to monitor their patients more closely, well, then we can have our cake and eat it too. The green line can continue to go up, and the red line and the blue line, the adverse public health consequences, can go down. We can have our cake and eat it too. I don't think we can. So I mentioned earlier that our opioid addiction epidemic begins in 1996, and this is why I say that. This is a graph showing you New York State data, but I could put up any state in the country and you would see the exact same trend. You would see that 1996 is the year that oxycodone prescribing explodes. Now, you could look at that, and some of you may know that 1996 is the year that OxyContin hit the market. And so maybe you would look at that and you would say, well, maybe that the reason that this is so striking is that this was Percocet, and now you've got a new opioid hitting the market and it's being prescribed widely, and so that's why you're seeing this trend. And it's true. I mean, a lot of this increase was OxyContin, but Percocet also started to go up in 1996, as did hydrocodone. So you can see here there had been an increase in hydrocodone prescribing, and there was an effort to get opioid prescribing. There was encouragement of opioid prescribing for chronic pain starting even in the 1980s. But it's in 1996 that the hydrocodone takes off as well. And it's in 1996 that the morphine explodes, and the hydromorphone, and the fentanyl. 1996 is the year that you see this very sharp change in medical practice. It's the year that you really see that we're prescribing more aggressively. And if any of you have ever been involved in efforts to change the culture of medical practice, you know how difficult it can be to get docs to change what they do. So how did this happen? What happened in 1996 that caused this very sharp change in the way that we were treating pain? And I think the best answer to that question came from a federal GAO report that was done that looked at the way that Purdue Pharma marketed OxyContin. And what they're showing you with this graph is the promotional spending on OxyContin, and they're comparing it to MS-Contin and to the fentanyl patch, and they're showing you the spending during the first 6 years of the release of each of those drugs. And their point is that Purdue Pharma was spending more promoting OxyContin than it had been spent previously for other narcotics. So by year 5, Purdue was spending about $30 million on promoting OxyContin. What was Purdue doing? Why were they spending all of that money? What were they interested in? Well, they were interested in a medicine that would perform well financially. Would have been hard for them to achieve that if OxyContin had only been prescribed to patients at the end of life with cancer, which is a population appropriate for a high dosage extended release opioid. They wouldn't have done very well because that end of life cancer pain is not a common condition, and patients aren't going to be on your medicine for very long if they're at the end of life. The way that you would do well with a medication is to see it prescribed widely for common conditions, and if they're chronic conditions, and if it's a medicine that's difficult to discontinue using, well, then you've got a really nice recipe for a blockbuster drug. And by year 5, their recipe worked well. By year 5, they were bringing in over $1 billion in sales on OxyContin. Now, they had a problem though. They wanted to see OxyContin prescribed widely. They wanted to see primary care docs prescribing it. They had a problem because in the 90s, the medical community understood before the release of OxyContin that opioids were not necessarily appropriate drugs for common conditions. And in fact, Purdue did focus groups that helped them figure out their marketing strategies. And they brought docs around a table, and they would say to the doc, would you treat your patient's low back pain with medicine like OxyContin? Or would you treat your patient's chronic headache or their fibromyalgia with long-term opioids? And the primary care docs said no. And Purdue asked, well, why not? And they said, well, I'd be worried that if I put a patient on a highly addictive drug long-term, many patients would get addicted. I'd be worried that patients would develop tolerance to the pain-relieving effect and they'd need higher and higher doses. I'd be worried that even if patients didn't clearly get addicted, the physiological dependence that would set in might make it difficult to discontinue the drug. So no, I wouldn't use opioids for those conditions. What Purdue Pharma did, though, was to reframe very good reasons for being cautious with opioids as barriers to compassionate pain care. And in 20,000 educational programs that they sponsored around the country, mostly with unrestricted educational grants, these were the chief messages in their programs. So the medical community starts to hear that we have been allowing patients to suffer needlessly because of an overblown fear of addiction. We start to hear that we've really been confusing addiction with physical dependence, that real addiction is very rare. Much less than 1% of your patients will get addicted. Physical dependence, that's going to happen to every patient you put on opioids, but physical dependence is clinically unimportant. Patients can be easily discontinued off of opioids. And it is true that physiological dependence on opioids is not identical to being addicted to an opioid, and it is true that every patient who takes an opioid, even for a week, is going to develop some degree of physiological dependence. It doesn't mean that they became addicted. But addiction and physiological dependence are very closely related. One of the reasons that opioids are so highly addictive is because of the physiological dependence, that very strong negative reinforcement when they try and stop using. And for a patient who's been on opioids for a long time, the most perfect pain patient who always takes their pills exactly as prescribed, if they've been on opioids for a while and you try and take them off, and once you get them through even the acute withdrawal, which is difficult, that patient may have months of feeling lousy, months of insomnia, months of leg kicks in the middle of the night, of irritability, depression, fatigue. And because the patient knows in the back of their mind, they know that all they'd have to do to feel better again would be to put one pill in their mouth. They also have cravings. So we don't have this bright line between physiological dependence and addiction. The reality is that it's much blurrier. And one of the other messages was that opioids are safe and effective for chronic pain. If this was one of the 20,000 educational programs, I'd be putting up and I was giving the talk, I'd put up a video and you'd see a patient come on the screen, because Purdue Pharma made these infomercials with real patients who were on OxyContin. And the patient would come up on the screen and the patient would say, I was in horrible pain because I injured myself on the job. I was out of work for months. I had no income. I was miserable, and now I'm on OxyContin. I feel terrific. I'm back at work again. I just bought my kid a bicycle, and I got my life back thanks to OxyContin. And the patient who appeared in that video, it wasn't scripted. The patient was on OxyContin, and the patient really felt great. He looked like he felt really great on OxyContin. And because Purdue liked that he said, I got my life back, they named the infomercial, I got my life back. All of the patients who appeared in this infomercial was, I got my life back. And the same patient who appeared in that infomercial saying, I got my life back because of OxyContin, would ultimately lose his life because of his opioid addiction. An investigative journalist went back to see what happened to the poster children of OxyContin. What we now know, especially with data from workers' comp, is that if you treat an injured worker's chronic pain with long-term opioids, the worker is less likely to go back to work again compared to any intervention you could have offered them. We know that for most patients with chronic pain, opioids are not safe or effective. The campaign that was launched by Purdue Pharma was multifaceted. It went way beyond these educational programs that were sponsored. One of the things that Purdue did was to create pain patient organizations like Partners Against Pain and the American Pain Foundation. These were organizations meant to look like grassroots groups of pain patients advocating for other pain patients. But these weren't grassroots organizations. These were AstroTurf organizations. They were artificially created by the industry to advocate on its behalf. And this is something we've seen ever since with other medicines when they're released. You now have patient organizations formed to advocate for conditions we didn't even know existed. Binge eating disorder, there's now, and all of these new, I'm sure we're going to have a new group for people with opioid-induced constipation. So the playbook that Purdue created is really being used now by other organizations. They gave money to professional societies like the American Academy of Pain Medicine, the American Pain Society. They didn't create these organizations. These were professional groups that had been doing really good work. And their advocacy had really been for interdisciplinary pain care programs. Pain experts understood that opioids were not really great drugs for chronic pain. But when the funding was to advocate for opioids, you saw their tune change. And the American Academy of Pain Medicine, the American Pain Society issue a consensus statement in, I think, 1997, saying that we should be prescribing opioids more for chronic pain, and that the risk of addiction and even the risk of overdose death has been overblown, that we shouldn't worry as long as you titrate the patient up slowly. The Joint Commission, as you all know, introduced pain standards, the smiley faces and the frowny faces, that that are, you can't go into a hospital without seeing them. Of course, screening patients for pain would make sense if they just had surgery, showing them smiley faces and frowny faces. If the patient has a developmental disability or dementia, they might be in pain and they can't communicate, showing them smiley faces and frowny faces and making sure they're not in pain. That, of course, would make sense, but that's not what the Joint Commission required. They required that we assess all patients in all settings, outpatient primary care, mental health. If a patient came into the mental health clinic at my last hospital and wanted to see a therapist because they've been anxious or depressed, before we could sit them down with a therapist, we had to show them the smiley faces and the frowny faces. And if they circled the frowny face indicating physical pain, policy read, refer to pain management. And when they got to pain management, what do you think? There was a good chance they'd be prescribed. This was really brilliant what they came up with. State medical boards started to hear that there's a chilling effect in America, that doctors really want to treat their chronic pain patients with high doses of opioids, but they're afraid they're going to get into trouble. They're afraid they're going to get sanctioned by the medical board. Medical boards start to hear that they're part of the problem of untreated pain in America, and they've got to let their doctors know that opioids are safe and effective, and that they need to let their doctors know that they will not be sanctioned based on prescribing aggressive quantities or doses, but that they will be sanctioned for undertreatment of pain with opioids. Now, I don't want you to think that everybody was out there promoting opioids because Purdue Pharma and other opioid makers were stuffing money into people's pockets. They certainly were stuffing money into some people's pockets and some of the people who were leading this, but the vast majority of docs who were involved in this, and I think some of the organizations as well, really fell for it. There was this belief that opioids are a gift from Mother Nature, and we're letting patients suffer needlessly because of an overblown fear of addiction. We've been confusing addiction with physical dependence, and they're really different, and addiction is really rare, and we can be more compassionate. There were many docs out there teaching their residents, and those same educational messages, docs who had no financial relationship with Purdue Pharma. So I mentioned that we were told that the risk of addiction was much less than 1%. And where did that statistic come from? Well, I want you to imagine you're a young doc and you're reading your textbook. You're just out of training. You're reading your textbook, your chapter on pain and addiction, and you come across the statement that much less than 1% of patients will get addicted to opioids when put on them long term. And it strikes you as strange because you're remembering your medical school pharmacology, and you realize, gee, that oxycodone molecule and that heroin molecule, these are really almost the same drug. How could you put someone on a highly addictive drug and much less than 1% would ever get addicted? How could that be? So you turn to the back of the chapter in the textbook to see the reference. What you would see is this: Porter and Jick, addiction rare in patients treated with narcotics, New England Journal of Medicine, 1980. It's in the late 90s through the 2000s. Everybody's citing this paper. And look at it, and maybe you want to really know what they did, so you go online to PubMed to see the abstract. Nothing comes up. Strange. Maybe because it's from 1980, it's so old, maybe that's why you're not getting an abstract. Well, this looks pretty good. New England Journal of Medicine, it doesn't get better than that, and the title looks pretty good. And so maybe it's true. Well, let's say you're still not buying it. You really want to see what they did in this study, so you make your way to the medical library, and you pull out the 1980 volume of the New England Journal of Medicine to see what people were referring to as a landmark study that proved we didn't need to worry about getting patients addicted. What you would find out is that it wasn't actually a journal article. It was this, a one-paragraph letter to the editor. That's Porter and Jick, a one-paragraph letter to the editor describing a chart review study of hospitalized patients who had been given morphine or Demerol while hospitalized, and they only found, I think, 4 charts where a patient suddenly appears drug-seeking after being given an opioid in a hospital setting. This, of course, tells you nothing about the risk of addiction when you put patients on long-term opioids, yet this is the evidence that was used. The idea that when you treat patients long-term with opioids, that you may be more likely to harm your patient than help them, it's getting out there now. And I made this slide a while ago. These are different editorials and articles with the message that I've been giving you. But since I made this slide, it's almost every week now there are studies coming out demonstrating that putting patients on long-term opioids is a really bad idea. AHRQ did a review of all of the available evidence on long-term opioid use, and what they found out is we really don't have evidence that putting patients on opioids helps them. And we do have evidence of serious risks that are dose dependent. When you have a medical intervention, surgery, medicine, whatever it is, a medical intervention where you don't know that the intervention is going to help a patient, but you have really good evidence that it could harm them, that the benefits are questionable and the risks are clear, that's a medical intervention that should be prescribed rarely. And unfortunately, opioids are still routinely prescribed for chronic pain in the United States. So how do we bring the epidemic under control? Well, this is an addiction epidemic, and addressing it is similar to addressing other disease epidemics. We have to prevent people from getting the disease. We have to prevent people from new cases of opioid addiction, which really boils down to getting the medical community, doctors, dentists, nurse practitioners, PAs, to prescribe more cautiously so that we don't directly addict our patients and so that we don't stock people's homes with a highly addictive drug. For really millions of Americans now who are opioid addicted, we have to see that they access effective treatment. If we only were to focus on curtailing overprescribing, we'd have to wait for the generation to die off that have become opioid addicted, and we'd see heroin continue to flood in. So you have to see that people are accessing effective treatment. You have to close pill mills. The pill mills aren't creating addiction. It's people who are usually already opioid addicted that are finding pill mill docs, but the pill mills are responsible for many overdose deaths. So there is a role for law enforcement. And I think the supply control has sort of a bad reputation because people think of the war on drugs, which deserves a bad reputation because what it really meant was mass incarceration of people with addiction. And it was when you had an epidemic that was disproportionately affecting low-income, non-white populations, we really saw a law enforcement approach. We're not seeing that now that we've got an epidemic hitting mainstream white America. But there is a role for law enforcement as well. Now, if bringing the epidemic is under control is as straightforward as what I've just said, why is the epidemic still getting worse? And why did, it was very clear, even by 2001, the prescribing had taken off at a rate higher than could be clinically needed. Why did we allow the epidemic to continue getting worse? Why haven't we brought it under control if it would be so straightforward? And I think one of the reasons is that from the beginning of the epidemic, policymakers were accepting the industry's framework of the problem. And this is how the pharmaceutical industry and its pain groups have framed our opioid crisis. What the policymakers hear, and this is still repeated over and over again, what you'll hear is we have two problems in America. We have the problem of untreated chronic pain, and we have the problem of drug abuse. They like the term abuse better than the term addiction. We have the drug abuse problem, and we have the chronic pain problem. These are two important public health problems, and let's not make the pain problem worse in our effort to address the drug abuse problem. And the idea there is that we've got these two distinct groups, and that the harms of opioids are really limited to the drug abusers, and opioids are helping millions of patients with pain, and any kind of reduction in prescribing would worsen the pain problem. This slide was shown at an FDA meeting by the head of the American Academy of Pain Medicine at the time, Lynn Webster. And this was a meeting to discuss the upscheduling of hydrocodone combination products. And I was there representing PROP, and we were there saying that hydrocodone is in the wrong schedule. It should be in the same, Vicodin should be in the same schedule as Percocet, which is Schedule 2. Lynn Webster was there arguing that if you upschedule hydrocodone, that you are going to make it more difficult for this woman to access opioids. You'll be punishing the pain patients for the bad behavior of the drug abusers. And what we've really been saying is that we don't have these two distinct groups. There's tremendous amount of overlap. 35% of patients in one study met criteria for an opioid use disorder, DSM-5 criteria, in a study of people who had died of overdoses in the state of Utah during the 2008-2009 year. They looked at everybody who had died of a prescription opioid overdose, and they found that 92% of the people who had died of a prescription opioid overdose were receiving legitimate prescriptions from doctors for a chronic pain problem. Next of kin believed that their loved ones were also addicted, but they were legitimate pain patients. The message is beginning to change. We're now finally seeing a focus on overprescribing as the driver. I'm going to finish up here on this one last point, which is, and I'll talk more about it later, but this is the AIDS epidemic. And you can see it's been a very similar trajectory for the overdose deaths. It starts in 1996, but it's really followed the same pattern. How did we make AIDS deaths drop like that? We turned HIV into a chronic disease from a terminal disease because we introduced effective treatments, medicines to treat HIV. We've got medicines that I think could help us do this now, particularly buprenorphine, for our opioid crisis. And unfortunately, we need to do better on access. So in summary, the United States is in the midst of a severe epidemic of opioid addiction and overdose deaths. To bring this problem under control, we need to prevent new cases of opioid addiction, and we have to see that people who are addicted receive access to effective treatment. Thank you.